My name is Taylor Robertson, and I am an inpatient therapist at Baton Rouge Rehab Hospital. I am a certified brain injury specialist, and I have a certificate in visual rehabilitation. Today, I will be providing a brief overview of the visual system and just how devastating damage to this system can be for our patients who have sustained a brain injury. First and foremost, the identification and management of visual dysfunction after brain injury is a team effort. Studies show that 90% of all of our patients that sustain a head injury of any severity, either traumatic or non-traumatic, are likely to experience some symptoms of visual dysfunction. This can include blurry vision, sensitivity to light, reading difficulty, increase in headaches, reduction or loss of their visual field, and/or experience difficulties with eye movements. Attempting to complete even the most basic of life tasks like dressing, bathing, or walking with any one of those previously listed dysfunctions could contribute to the problematic behavior we typically think of when we hear the term brain injury. This includes frustration and irritability. In addition, visual dysfunction can create issues with balance, coordination, and depth perception, ultimately increasing a patient's likelihood of falling while in the hospital and also after discharge. The good news is, with understanding how these visual symptoms appear and with the proper management of the patient and the environment, we can greatly reduce these behaviors and potential fall hazards to improve patient performance and independence across all areas. It's also not uncommon for a patient to only exhibit disturbing visual symptoms at specific times of day, in a particular environment, or even just during certain tasks. Therefore, it is imperative that everyone on the patient's care team, or those that have any interaction with the patient, be aware of those possible signs and symptoms of visual dysfunction, as well as maintaining open communication with one another throughout the person's length of stay to monitor any of these changes or improvements. Now, let's discuss the basics of vision. We often think about vision as simply being what we see, and if what we see is clear. However, vision is much more than that. It also includes how our brain makes sense of what we see, otherwise known as our visual perception. By definition, vision is a dynamic process of identifying, organizing, interpreting, and understanding what is seen to derive meaning and then direct our actions. It is a learned process consisting of a foundation of complex brain pathways formed between the eyes, the brain, and the body. It is created during the prenatal period and then refined throughout the first years of life. It's important to note that the majority of all sensory information received by the brain comes from our visual system. Therefore, if the visual system is not working properly, it can greatly affect our balance, movements, and control, ultimately affecting our ability to care for ourselves or others, drive, work, manage finances or medications, sleep, or even maneuver around our environment. In order to understand how visual dysfunction can be devastating to our patients, we must first appreciate how the eye functions in regards to movement, and then understand how the brain is able to receive, interpret, and convert light to a recognizable image that we can then act on. First, the eye is considered to be a slightly asymmetrical globe that sits within a protective bony socket called the orbit. There are 6 muscles, known as extraocular muscles, that are situated around the eyeball, located within the orbit, and then attached to each eye. These muscles are innervated by cranial nerves, and they're responsible for moving the eyes up, down, side to side, and also rotating the eye. Therefore, if damage occurs to this bony socket or to one of those cranial nerves, either by direct or indirect trauma, it's likely that the eye will have difficulty moving in a particular direction and then can ultimately create that unwanted visual disturbance known as double vision. The eye itself has many parts. Beginning at the front of the eye, you will notice the cornea, pupil, iris, lens, ciliary body, and suspensory ligaments. These structures, along with the others pictured, work together, allowing specific amounts of light to enter the eye. It's key to note here that all visual images initially begin as waves of light. Once those light waves enter the eye, they are converted into electrical signals or impulses and passed on to the brain through the optic nerve. Once those signals reach the visual cortex, located in the back of the brain, visual processing occurs, allowing us to create, generate, and recognize images. As you can see, the visual pathway is extremely complex. It starts at the back of the eye and makes its way all the way to the back of the brain. With a pathway so long and so wide, it's not hard to see how injury to any part of the brain could easily damage these pathways and disrupt vision. When looking at the image on the screen, you can see that each eye contains two visual fields, a left and a right. They're represented by the two different pathways coming from each eye, one red and one blue. Each eye perceives this information from each of the visual fields and then sends that information through the pathways we discussed. So therefore, patients with damage on one side of the brain can lose vision not just in one eye, but on the same side of each eye. When the brain itself is damaged, patients can experience difficulty processing and organizing all of this information, therefore leading to complaints of extreme light sensitivity, also known as photophobia, dizziness, headaches, or even eye strain. So what does this mean for you and our patients? Let's just say you've just been assigned a patient on the brain injury unit. If your patient is having issues with their vision, you might see one of the following signs. First, patients may have blurry or double vision. Therefore, they may have a result reading, focusing on their phone, TV, or even items within the room. They might also complain of the lights being too bright or the environment being too distracting. If they're unable to communicate, they may exhibit other signs of discomfort, such as fidgeting, withdrawal, avoidance of interaction, or even increased irritability. These patients might have increased complaints of headaches, nausea, or motion sickness, and you might also notice they have trouble sitting at the edge of their bed or in their wheelchair due to these visual problems. These visual problems affect their balance, posture, and even the way that they interpret their environment. Patients with these visual deficits may have difficulty judging where their body is in space, and they may result in abnormal postures like leaning far forward, backwards, side to side when sitting or standing or even walking. They might even complain that the floor is tilted. Finally, because vision is so critically important to our ability to interact with our environment, locating necessary items and carry out tasks, someone with these visual deficits may require increased time or increased assistance to complete their self-care routine. Because vision occurs along a pathway involving the eyes, cranial nerves, and multiple areas of the brain, functional deficits are determined by the location of the actual damage. Often, there is more than one cause for our patient's symptoms. Sometimes it can be the eyes causing the problem, and other times it may be the processing issues occurring in the brain itself. This slide lists the most common types of visual deficits one may experience following a brain injury. Let's break them down to better understand their implications, as well as discuss various strategies you can implement to reduce our patients' complaints of visual dysfunction. The most common visual impairment you will hear discussed is a visual field deficit. A visual field deficit is defined as the loss or decrease of vision in one side of the visual field in one or both eyes, ultimately leading to a blind spot. This occurs from damage at any point along the previously mentioned visual pathway. Often, these patients are going to be unaware of their visual field deficits as their brain attempts to compensate for this deficit by fusing images from both eyes together. However, this can result in an incomplete visual field, which is dangerous, especially for our patients who are unaware that the problem even exists. When interacting with a patient with a visual field deficit, you may notice that they frequently bump into objects on the affected side, lose track of important personal items like cell phones or call lights, or even experience difficulty reading or locating items on a table if placed within that lost visual field. These patients might also appear as if they're avoiding the food on their plate that is placed on their affected side. A visual field deficit can occur either with or without another visual field deficit, known as visual neglect. Visual neglect, otherwise known as unilateral inattention, is exactly that. It is an attention disorder that arises from damage to the brain in which the processing of information from the affected side of the body is impaired. This is usually more common in patients with damage to the right side of their brain, resulting in an inattention to the left side of the body or any stimulus presented in their left visual field. With a visual neglect, the visual pathways themselves are intact, however, the person's awareness is impaired. This is why their symptoms can seem very similar to someone with a visual field loss. A patient with a neglect or inattention might have difficulty locating objects on their affected side, but unlike patients who only have a visual field loss, these patients with inattention may tend to neglect the affected side of their bodies. They may only shave half of their face, wash one half of their body, or only dress the limbs on the unaffected side. If you have a patient diagnosed with or exhibiting symptoms of a visual field loss or neglect, these are a few things you can do to help your patient not only function with their visual field deficit, but also begin to recover. The goal of treatment for these patients is to increase awareness to the forgotten side to help them compensate for the damage to their visual field. We also want to make sure that we're setting up the environment appropriately to increase the patient's interaction with objects and/or people on both their affected and unaffected sides. Initially, you should address the patient on their good side or uninvolved side to ensure you have their full attention and understanding. However, as they recover and their awareness begins to improve, you can and should start addressing them on their weaker side to provide greater opportunities for carryover of these scanning strategies. Scanning is a common strategy we implement in therapy to increase awareness to the forgotten side. Making sure you always set up the room or environment to encourage carryover of scanning into that neglected field is crucial to recovery. You can do that by placing all non-essential but motivating items into that neglected side, such as the television, radio, or even setting up the bed so the window is on the patient's weaker side. However, to ensure our patient is able to easily call for help when needed, always ensure the patient's phone and call light is placed on their good side, and the patient is then able to verify to you where the call bell is located. Meal times can be particularly difficult for patients with visual field deficits or inattention. If they will be eating without direct supervision, always set up the tray so that the food items are placed within the patient's intact visual field or the side they're attending to ensure they are achieving adequate nutrition. If you will be sitting with the patient, try to come up with a strategy with the help of therapy, either by verbal cueing or anchoring, to enable the patient to scan to their weaker side and locate food on the entirety of their plate or tray. Anchoring is a strategy designed to draw the patient's visual attention to the weaker side. This can be done by placing a brightly colored piece of tape within the lost visual field. This encourages the patient to scan to that side to locate the necessary items or even avoid obstacles. You will often have to cue the patient to locate that brightly colored tape. To ensure our patients aren't getting overwhelmed, try to reduce clutter and other visual distractions within the room, especially on the patient's good side. Finally, family education is critical to ensure our patients continue to receive the same quality of care when we aren't present with them. You can share these strategies with the family and make sure they understand their role in their loved one's recovery. Encourage the family to visit with the patient on their weaker side to increase the patient's awareness of the impaired or forgotten visual field. The next visual deficit you might encounter is reduced visual acuity. This is defined as the clearness or clarity of vision. It describes how well we are able to see and what someone is referring to when they say they have 20/20 vision. A brain injury can often affect a patient's visual acuity regardless of how good their vision was before the damage occurred. A patient with decreased visual acuity may complain of blurriness, difficulty identifying details in a picture or in the environment, or even have difficulty with reading or focusing. You may notice that these patients begin to hold items closer or farther away in order to focus on what they are attempting to look at. And also, a patient with reduced visual acuity may complain of increased headaches, eye strain, or fatigue. Whenever you're interacting with a patient with reduced visual acuity, whether either assisting them with their morning care routine, completing hourly rounding, or transporting them to and from the gym, always double check that they're wearing their prescriptive lenses or glasses, if they typically wear them. If their glasses are not at the hospital, simply ask their family to bring them in. If the patient states that they do not want to wear their glasses or only needs them for reading, then simply place them within the reach on their bedside table and in their intact visual field. Reduced visual acuity may create difficulty when reading small print. When providing written information, like a dietary order sheet or newspaper, increase the text size and utilize a high contrast option such as black writing on white paper. You can also assist the patient with making appropriate modifications on their phone by increasing the size of their text. When assisting patients with their morning care routine or performing transfers, make sure the room is well lit so they can locate all of their necessary items and reduce the possibilities of a fall. Lastly, always monitor for patients' visual discomfort and communicate with the care team on any changes. Next, we will discuss patients that have oculomotor dysfunction. We have all observed or interacted with patients that have oculomotor dysfunction as a result of brain injury. However, we may not just have fully understood what we were observing at the time. These are those patients that have eyes that appear not fully aligned, they have difficulty moving them individually or together or moving them at all. As discussed earlier, there are 6 extraocular muscles that control the movements of the eyes. If there is damage to the nerves that control these muscles, it will result in weakness and ultimately affect the eye's alignment, ability to move, and their ability to function together purposefully. Patients with this dysfunction will often complain of double vision. They will have difficulty focusing or attending to tasks, appearing easily distractible, and have difficulty reading or following items or people moving across the room. These patients might appear clumsy and will likely require increased time with their self-care routine due to poor depth perception and difficulty coordinating head and body movements. They might also frequently rub their eyes or complain of increased dizziness or motion sickness at rest and with movement. To help patients with oculomotor dysfunction, first and foremost, ensure the patient has good posture with everything they do. Key points to consider regarding posture is to maintain the patient's feet supported either on the ground or their leg rest. Ensure their back is either properly aligned in an unsupported position, like when sitting at the edge of the bed, or is supported by their backrest in a straight-up position, and the patient is not tilted towards one side. A person's posture greatly impacts their visual performance and ability to interact with their environment. When entering and exiting the patient's room, ensure the room and bathroom are kept tidy and consider placing anything that is not being used in the patient's closet. Clutter can be highly distracting visually and can cause the patient to be susceptible to visual fatigue, as the patient's brain is having to spend extra time scanning across all non-essential items to locate what they need. With that being said, always keep commonly used items in their designated spot so a patient can easily locate them without having to work harder scanning their environment. If asking the patient to complete an important task that requires their entire focus, such as transferring out of bed, reduce all other possible visual distractions by turning off the TV or relocating their phone until the transfer is complete. Sometimes, a therapist may issue special glasses with tape applied to the lens in a certain way to assist patients with reducing their complaint of double vision. This approach is generally used to encourage strengthening of the weak muscles of an eye to encourage realignment of the eyes together. It is initially the therapist's responsibility to communicate the wear schedule of these glasses with the patient's primary nurse to ensure that the information is placed on the daily census. However, it is up to everyone to carry over the wear schedule. Therefore, if you are unsure, just ask. Lastly, but probably most importantly, is photophobia. This is also known as extreme light sensitivity. Due to the damage along the visual pathway and processing center in the brain is unable to regulate or properly interpret the amount of light entering the eye, resulting in light sensitivity. This creates an overwhelmed feeling in the patient. A patient with light sensitivity will often present with difficulty keeping their eyes open in a brightly lit room, such as the gym, dining room, or when sitting at the nurse's station. They'll have difficulty focusing on their self-care or mobility task, or express difficulty reading. They may often rub or squint their eyes, have increased tear production, or complain of seeing bright colored spots or have pain. It is not uncommon for these patients to refuse therapy, exhibit increased irritability, or appear non-compliant with staff. The 2 most important strategies in the management of photophobia are protecting the patient's eyes and modifying the patient's environment. We can easily reduce a patient's complaint of visual dysfunction by adjusting lighting within the patient's room or gym to a level that's comfortable for the patient and observing their response to these changes. This can be done by dimming the lights or turning off the overhead fluorescent light and opting for opening the blinds instead. We can modify the environment by reducing the amount of visual clutter within the patient's room and removing any unnecessary items from the bedside table. We can keep linens tidy and their closets organized. A therapist may also issue tinted or colored lenses to a patient with potential photophobia in order to reduce symptoms of visual discomfort. They will communicate a wear schedule with the primary nurse. Please ensure that the patient is wearing these glasses according to that prescribed wear schedule and provide any feedback to the care team. Lastly, these patients may be appropriate to rest between the therapy sessions in their room versus at the nurse's station or in other areas of bright lights and high visual distraction. As you now understand, there are many types of visual deficits that can occur whenever our patients sustain a brain injury. You also know there are even more signs of visual dysfunction that accompany these deficits, which affect our patients' ability to care for themselves or even participate in the most basic task. It is up to all staff members to utilize an interdisciplinary and integrated team approach to ensure the proper rehabilitation of our patients with brain injury.
Baton Rouge Rehab Hospital is proud to be a leader in inpatient and outpatient rehabilitation services in Baton Rouge and surrounding areas. We pride ourselves on a commitment to restoring lives through compassion and a dedication to excellence. As the frontline staff members at Baton Rouge Rehab, we achieve these goals and standards through a responsibility to attain the highest level of competence and consideration for the unique and specific needs of our patients. Participating in hospital-wide education and seeking out opportunities to learn and grow as an individual is what can set you apart as a top talent contributor to the hospital. The education provided to you today highlights the 4 values of Baton Rouge Rehab: compassion, integrity, teamwork, and excellence. When you take the knowledge you have gained and apply it to person-centered, excellent care, you are contributing to the excellence of Baton Rouge Rehab. Thank you for your dedication.